Hello everybody, this is Dr. Christy Day. I prepared this video and it aims to provide study tips for renal and urological disorders. The video is not a comprehensive lecture on the content material, but instead I hope to highlight some topics and focus your study. The major source of study this week is your textbook and course lectures, and this review is optional content. This is the topical list for your exam 3. And now this presentation may cover additional information that you may find helpful for practice, in addition to content specifically for your exam preparation. I have encouraged some of you to find outside resources such as videos and flashcards to supplement your learning. And then this depends on your learning style. I have found an informative medical level YouTube content provider called Rhesus Medicine, and you might want to check out their videos. I put a link below to their channel, and they're kind of cute. They use a lot of drawings and animation and they're not super in depth, but they provide real information that you might find helpful. Additionally, I found a relevant set of flashcards for renal and urological disorders on Quizlet, and I am going to share that also. Acute kidney injury, AKI, is also known as acute renal failure, and it's the sudden and rapid deterioration of renal function. AKI causes the inability to maintain acid-base balance, fluid balance, and electrolyte balance, and allows for the accumulation of waste in the blood. AKI now has a universal definition and staging system to allow for earlier detection and the management of the disease. It is defined by when one of the following criteria is met, and it's included on the slide. The serum creatinine rises 0.3 milligram per deciliter or greater within 48 hours. A 1.5 or 1.5 times greater serum creatinine from the week before, or the urine output is less than 0.5 milligrams per kilogram per hour for more than 6 consecutive hours. You don't need to memorize these values, but you should be aware of them and know that if you have a sudden change in renal function, consider acute kidney injury as a diagnosis. AKI is commonly caused by intrarenal injury associated with sepsis, renal hypoperfusion, or nephrotoxins. A major risk factor for AKI is surgery, especially for older patients or patients of any age with elevated pre-surgical creatinine levels. Community-based AI, and that's people not in the hospital, occurs more frequently among vulnerable populations such as individuals with underlying kidney disease, multiple myeloma, or diabetes. AKI is one of the potential risks related to open heart surgery or cardiac procedures. And for management, acute kidney injury it should be managed in acute care. It needs to be evaluated urgently and treated. And for the best approach to that is to do a direct admission, either through your collaborating physician or through a nephrologist, whoever can do a direct admission, or you can send them to the emergency department. Chronic kidney disease is a progressive loss of functional nephrons, which can eventually lead to end-stage renal disease. And if you think of a nephron in the kidney, think of it as a strainer or a screen. And when you get problems with the nephrons, then think of it as little holes in the nephrons, then the screen that can allow things to leak out, such as proteins. And as function of the kidney decreases, the signs and symptoms of renal failure may be seen. The time frame for development of CKT ranges from months to years in comparison with acute kidney injury, which occurs over days to weeks. CKD affects around 15% of the US population, and it can be asymptomatic, with around 50% of people with severely reduced renal function being asymptomatic. Around 750,000 people in the United States have end-stage renal disease, which is increasing. Women are more likely to have end-stage renal disease at 1.3 to 1.4 times males. The peak age onset for end-stage renal disease is between 65 and 75 years. And remember, because it takes time to go from chronic kidney disease at the lower stages and work your way through. In addition to higher incidence in older people, the disease tends to have higher morbidity and mortality in this age group. African Americans are 3.9 times more likely to have end-stage renal disease and 6.7 times more likely to have hypertensive end-stage renal disease. It's estimated that HIV-associated nephropathy may soon be the third leading cause of end-stage renal disease in African Americans aged 20 to 64 years. Diabetic nephropathy is the most common cause of end-stage renal disease. And if you take diabetic nephropathy along with hypertensive nephropathy, these account for 70% of the cases. And you can read more about the other causes, risks of chronic kidney disease in your textbook. Because of the significant functional reserve of the kidneys, symptoms of chronic kidney disease do not generally appear until renal function measured by GFR declines to 10 to 15% of normal. At about 30 to 40% of normal GFR, we start to see blood chemistry changes, but these patients typically remain asymptomatic. As CKD progresses, dermatological signs or symptoms and signs can be reported with the patient complaints of pruritus and dry skin. We may see GI symptoms such as anorexia, nausea, vomiting, and hiccuping. Neurological complaints may include emotional lability or depression, insomnia, fatigue, especially on exertion, confusion, headaches, seizure, and finally coma. These are usually due to electrolyte and metabolic imbalances. There's also maybe general complaints such as an odor of urine in the breath and perspiration, shortness of breath, that's usually from fluid overload, a metallic taste in the mouth, impotence, nocturia, and muscle cramps. In the later stages, the patient may have pale skin due to anemia. There may be uremic frost, which I've only seen one time, and hyperpigmentation. You may also see bruising, peripheral neuropathy, peripheral edema, and altered mental status, as well as oscillatory crackles in the lungs and pericardial rub. There may be an elevated blood pressure and a hard, rapid bounding pulse, and these are from fluid overload. And those are classic signs that you learned about as an RN too. Some of the abnormalities are a result of accumulation of toxic metabolites, while others are caused by underproduction, such as vitamin D deficiency and erythropoietin deficiency. And then we see overproduction of renin. In renal artery stenosis, there can be a bruit auscultated in the flank or the mid-abdominal region over the affected renal artery. Urinalysis is a key component in the evaluation of urological and renal problems. In your textbook, Table 32.1 is an excellent reference for understanding the different elements of the UA. And I recommend that you review this chart, and it'll give you some of the abnormal findings, and then also some of the differential diagnoses that you may see associated with those findings. I noticed that the textbook provides a detailed explanation of specific gravity and as it relates to acute kidney injury, whereas the table doesn't specifically point out acute kidney injury in reference to specific gravity. And this is because acute kidney injury can result in both high and low specific gravity. For example, dehydration, you will see increased specific gravity. And a pre-renal cause of acute kidney injury is dehydration and decreased blood flow. And this can show elevated urine specific gravity or a concentrated urine. You will also see low specific urine specific gravity and other causes for acute kidney injury. You can also read additional information on proteinuria in your textbook. Most of the causes of proteinuria are serious. Remember how we talked about the nephron screen developing holes that allows proteins and other byproducts to leak through into the urine? But there can also be benign causes of proteinuria, such as excessive exercise. A more in-depth discussion of hematuria will be later in the presentation. For chronic kidney disease diagnosis and workup, the best index of chronic kidney disease is the GFR. While serum creatinine can track the progression of chronic kidney disease, the GFR is your diagnostic lab for CKD. GFR is normally well above 90, and some people have GFRs up to 130 in healthy people. The GFR can decrease to 40 to 50% of normal with only small changes in the serum creatinine levels. And the trend or graph of the GFR is more important in assessing renal function and stability in chronic kidney disease than a single test or value. And that's because, like we said, a small change in serum creatinine can affect the GFR. So you want to look at it over time, repeated measures. If your CMP does not show an estimated GFR, there's calculators within the app, such as Hippocrates and online tools to calculate the GFR using creatinine and other patient data. Upon diagnosis of chronic kidney disease, be sure to check a CBC for anemia, check a urinalysis, vitamin D, ammonia, an A1C screening for diabetes, check their lipids, and renal ultrasound in all cases of new onset chronic kidney disease to look for other pathologies such as obstructions. For the management of chronic kidney disease, there's general principles that your book talks about. Diagnose and treat the underlying cause of chronic kidney disease is number one. And I really like this chart that I found on a website. It was in a journal, and it really puts it into perspective of controlling the risk for progression of chronic kidney disease. So you're going to want to modify all those risks and have tight control of your diabetes, hypertension, lipids, anemia, fluid and electrolytes. You want to kind of make sure all of that is in balance and well controlled. Excuse me. Over time, you want to monitor changes in renal function. You want to keep track of it. Remember, we talked about the trend. Conservative management of symptoms and disease in those early stages, and a referral to a nephrologist for more aggressive treatment in stages 3 to 5 with co-management. And you can, if you go to any of these drug rep presentations and you have a nephrologist talking, they like to see these patients much sooner than stage 4 and 5. In fact, they wouldn't have any problem with most of them with you referring somebody stage 2, but especially in stage 3. Glucose levels in hypertension must be strictly controlled in diabetic patients with a target A1C of less than 7. And this is, diabetes goals are individualized and it depends on your patient age and their preferences and what they want. So, but the recommendations are for less than 7, but it may be different for your patient. For any patient with proteinuria of more than 1 gram per day, the target blood pressure is less than 125/75. So there's some specific things in there regarding, you can look at hypertension in people that have chronic kidney disease. Given the importance of maintaining renal perfusion, systolic BPs lower than 110 should be avoided. So we don't want hypotension. ACE inhibitors or ARBs should be used for BP control in patients with diabetes, giving their renal protective effects. For hypertension management, like we said, ARB and ACE are used, but they should be avoided in patients with renal artery stenosis. And this is why in patients with renal resistant hypertension, people that you've got on 3 or more medications or 3 medications, they should have and they're still not controlled, they should have a renal ultrasound because you want to make sure that you're not doing anything to harm your patient with their medicine management. And there's a table 45.1 in your textbook with additional details on the recommendations for management according to the staging of chronic kidney disease. Other measures to relieve symptoms such as pruritus include skin moisturizers, menthol, phenol lotions. They can try capsaicin cream or an antihistamine such as Benadryl, which is, on the Beers list for dangerous medications in older people. And vitamin E may be helpful in treating muscle cramps. All nephrotic toxic agents should be eliminated or avoided. And that's why you're always, doing your creatinine or your GFR before they get a radio contrast dye, NSAIDs, aminoglycoside antibiotics. Watch, you try to use medications that are processed by the liver rather than the kidney. All those things, because at this point, when your patient has chronic kidney disease, you want to preserve the kidney function as it progresses through the stages. Hematuria is defined as blood in the urine and can be both visible, which is gross hematuria, or occult, which is microscopic hematuria. Asymptomatic microscopic hematuria has many benign causes such as infection, menstruation, vigorous exercise, viral illness, and trauma. So asymptomatic microscopic hematuria is often a incidental finding. Urinalysis dipstick has good sensitivity for hematuria, but moderate specificity. So this means that the dipstick can have false positive for blood. And this can be confirmed on microscopic examination. And just so you know, it takes a small amount of blood for the urine to appear red. On microscopic exam, there is a direct relationship between the quantity of blood found in the urine and the likelihood of pathology. The causes of hematuria are grouped according to anatomical site of the blood source. You can find the table 43.1 in your textbook, which lists many causes of hematuria by anatomic region, as well as systemic and functional causes. You can read about this in the textbook. A drug history is important because many drugs can cause the problem. Dietary substances can also be bladder irritants, as well as other substances such as alcohol, cigarettes, caffeine, spices, tomatoes, chocolate, aged cheeses, citrus fruits, and soy sauce. Your textbook highlights the geriatric incidence of hematuria in males. In males greater than 50 years old, 2.4% of hematuria, 2.4% of these people have urinary tract malignancies. In males greater than 60, the incidence of urinary tract malignancy increases to 9%. In older males with gross hematuria, the rate of associated malignancy is as high as 20%. And remember, this includes the prostate. Beta-lactam antibiotics, sulfonamides such as Bactrim, NSAIDs, rifampin, ciprofloxacin, allopurinol, cimetidine, and phenytoin can all cause nephritis, which can result in the destruction of nephrons, impaired renal function, and hematuria. Papillary necrosis can result from the use of anticoagulants such as warfarin, heparin, aspirin, and NSAIDs. Glomerulonephritis can be caused by the use of hydralazine, amphetamines, NSAIDs, allopurinol, and others. We're seeing NSAIDs mentioned over and over in renal problems. Transient hematuria occurs on a single occasion, whereas persistent hematuria occurs on 2 or more consecutive voidings. Both transient and persistent hematuria can be a sign of serious underlying disease. The presence of both proteinuria and hematuria is suggestive of glomerular or interstitial nephritis. But both of these findings can also be caused by excessive exercise. And this was first identified in military personnel who were marching for long distances. In an athlete with intense exercise, there may be transient hematuria. So this is a lot of it's patient education because it's very alarming. This is usually, they usually see gross hematuria and it brings the patient into your clinic. But by the time you do the urinalysis, the hematuria may be resolved. In this case, patient education and repeat urinalysis are recommended. When hematuria is of renal origin or suspected renal origin, additional lab tests should be completed. There's a complete list in your textbook of all these specialty labs. And if you have a patient who falls into this category, you can look up these specialty tests at that time and order them. In addition to specialty testing, be sure to get a urine culture, CMP, CBC, VDR to rule out syphilis. And you want to treat the underlying cause. If there's a UTI, treat them and reevaluate the patient for hematuria 2 weeks after completion of the antibiotics. You don't want to assume that the hematuria was caused by a UTI. You need to recheck it. And for renal causes of hematuria, refer to a nephrologist. For urological causes, of course, refer to a urologist, sorry. Registered nurses generally have a pretty good education on the definitions of incontinence. And I'm not going to go into a lot of depth in this video presentation on urinary incontinence. Be sure to be able to diagnose the type of urinary incontinence, know the names of them, know the signs and symptoms. And you can find a good YouTube video if you want to review, if you want more information, and also read more in the textbook. For urinary incontinence management, I encourage you to look at table 44.1 in your textbook for the common signs and symptoms and management of the different types of urinary incontinence. As a nurse practitioner, you should be able to accurately diagnose the type of urinary incontinence and to be able to select effective interventions for incontinence. Nephrolithiasis is a condition in which stones, renal calculi, originate in the kidney, and they can also then travel down the ureters. The stones form calcium salts, with about 75% to 85% of stones being calcium salts, and uric acid, among others. But we'll see more uric acid stones in hot, dry climates where there's a little bit more dehydration. Renal stones can actually cause acute illness with urinary tract obstruction, infection, and severe pain in adults. And this will bring them to the hospital, to the urgent cares, and also to clinics. Renal calculi most often occur in people 20 to 60 years, but with the peak incidence in those aged 20 to 30 years, which I found interesting. The typical patient may report a sedentary lifestyle or occupation that involves exposure to high environmental temperatures. You can see in table 44.2 in the textbook the type of stones, how they look in the microscope, the causes of those type of stones, and management of the stones. Calcium oxalate stones occur more often in males, where struvite stones are more common in females. Renal stones can occur because of obstruction, urinary stasis, infection, dehydration, urinary concentration, increased consumption of calcium or vitamin C and D, excessive excretion of uric acid, or vitamin A deficiency. Hereditary factors can also predispose the patient to kidney stones. For signs and symptoms, we're looking at pain, urinary obstruction, all the things. You guys have probably had quite a bit of experience with this, both in your undergrad and in your clinical experience. You can see some nausea, urinary frequency, vomiting, diaphoresis, dysuria, hematuria, and weakness. And they may report that they had a recent or chronic UTI. And this is on exam, you're going to see those CVA tenderness, and you're also going to look at labs to diagnose. For the urine sample, you're going to see alkaline pH. You may have a patient that is on calcium supplements, a high diet in animal fat, a family history, maybe gout, and low water intake. And so diagnostic workup should begin with a routine UA, complete blood count, blood chemistry, and urinalysis may be normal, or it may show RBCs, WCs, crystals, or casts. You'll see that. It may show bacteria, pus, alkaline, or pH, and there may even be blood if those stones are traveling down the ureters and have caused some bleeding. For a really nice comprehensive review on nephrolithiasis, I like this YouTube presentation. It's very professional. You may have some ads, but just skip by those. But for additional information, for those audio visual resources, this is a good one. I'll put the link down below. A lower urinary tract infection occurs when the normally sterile environment of the urinary tract system is invaded by pathogenic bacteria. Infections of the lower urinary tract can occur in the urethra, bladder, and the prostate in males. UTI can occur at any age, but is more prevalent in sexually active adults, very young children, or frail older adults. Females older than 65 years have approximately double the rate of UTI than the overall female populations. Other populations at risk include individuals who are sexually active, those who use spermicide, gels, and diaphragms, with other predisposing conditions such as suppressed immune system, pregnancy, urinary obstruction, urinary stasis, catheter dependency, neurogenic bladder, diabetes, and those with a history of UTI. There's other things besides bacterial infection that can cause lower UTI symptoms. And you want to kind of review those. I like this table that I found because, we have interstitial cystitis, we have asymptomatic bacteria, we have all kinds of stuff that you can look at when you have a patient with lower urinary tract infection symptoms. Because, of course, we're looking at antibiotic stewardship and all that. So you want to make sure that you zero in and diagnose accurately an infection and not overtreat. Infections can be acute, chronic, recurrent, complicated, or uncomplicated. Acute infections are characterized by the onset of UTI in a previously symptom-free individual. Infections can become chronic when they're unresolved after standard treatment is rendered, and UTIs become chronic because of obstructions, antibiotic resistant bacteria, or the presence of multiple strains of bacteria that are not susceptible to the antibiotic therapy prescribed. A UTI is considered recurrent when it occurs again within 2 weeks of the original infection. A complicated UTI is either an acute or chronic infection that is accompanied by factors that predispose a patient to the infection or make a treatment more difficult, such as indwelling catheters, underlying chronic disease, systemic symptoms, or pregnancy. An uncomplicated UTI is one that can be resolved without addressing any other factors and is localized to the lower urinary tract. Diagnostic, of course, is a urinalysis, urine culture. E. coli is by far the most common offending organism. Other diagnostic tests can be ultrasound, CT scan, depending on patient symptoms and their evaluation. Assessment, your physical exam, and symptoms may be burning, frequency, urgency, pain during or after urination. I always find it's really helpful to say, is the pain on the outside or the inside? Because some people will say it hurts when I pee, and they mean that they have a yeast infection that's burning. So you can have blood in the urine, you can have foul smelling urine, you can have a low abdominal or back pain, incomplete bladder emptying sensation, like they go and they don't feel like they went all the way. If a fever is present, always consider pyelonephritis. Urinalysis, you may see WBCs, positive leukocytes, positive nitrites. And on the culture, the bacterial count will be over 100,000. And culture and sensitivity, you don't always have to get a culture and an uncomplicated UTI. Patients are very good at describing and knowing the symptoms of UTI if they've had them before. So we don't always have to have a culture. And by all means, if they're ill and they have signs of an uncomplicated UTI, and maybe your urine dipstick is not completely diagnostic because the nitrates are going to take time. Leukocytes can be caused by by vaginal discharge, other things. So if you highly suspect, there's high suspicion for uncomplicated UTI, or you need to get that treated, because the next thing you know, you're going to have a patient that's got pyelonephritis. So you don't want to wait. Let's say you get your urine culture on a Thursday, and the clinic is closed on the weekend. Nobody's monitoring those labs, whatever. It comes 5 days later, you're like, oh, yeah, I guess this patient did have an infection, and now you've got a very ill person, something that's progressed. And then again, sometimes you talk to them after that culture, and they were drinking lots of water and treating the pain, and they've washed it away. They can get well without antibiotics with a bacterial cystitis. On a urine culture, they may identify infectious bacteria. They may also identify skin contaminants, and it's good to know what those contaminants look like on urine cultures. What type of skin contaminants you might see. Collection is always important, as you learn that as an RN, how to collect a urine culture. So the first line treatment of choice for uncomplicated lower UTI is nitrofurantoin, excuse me, given for 5 days. Surveillance has revealed that increasing rates of resistance in E. coli to ampicillin and sulfonamides like Bactrim, whereas only a small percentage of those E. coli were resistant to nitrofurantoin, and that's microdalton and macrobid. Macrobid, I think, is the BID. That's why it's called macrobid, and it's easier to dose. Contraindications to nitrofurantoid include sensitivity, allergy, renal function impairment with the creatinine less than 60 is what the book is saying, anuria, pregnancy, labor or delivery, and it's not indicated for the treatment of pyelonephritis or any type of, kidney abscess or whatever. It's also, nitrofurantoin is also effective against some gram-positive cocci, such as Enterococcus faecalis and other uropathogens. It should be used as empirical therapy for uncomplicated UTI only. So when you have a patient that I described that you're pretty sure, they're high probability and you want to treat them empirically and not wait for your culture results. So you can still get a culture, have them get a urine while they're there today, start them on their nitrofurantoin, and then wait for the results. And then you can see if you treat it appropriately, but this kind of makes sure they don't get too sick. Although the use of Bactrim as empiric therapy is no longer the first line choice in most parts of the country, it may be indicated depending on the resistance pattern in your area. So it's indicated, Bactrim is indicated as first line treatment in complicated UTI in female patients who are not pregnant. So now we're talking about complicated UTI. So after completion of antibiotic therapy, we don't usually do a follow-up culture. But if there is a recurrent infection, we can. The book says to wait a week after they complete the antibiotics, but I'm hearing 2 weeks in practice. And especially in people, you want to recheck in people that are pregnant and those that are prone to complicated UTI. They have recurrence, things like that. I'm going to recommend the Dr. Boland's review for renal and urinary tract infections, and this includes pyelonephritis. It's a pretty succinct presentation, and he gets right to the point. I think it's 10 minutes or less, and I recommend this. I'll put the link below to learn more about urinary tract infections, both upper and lower. I hope that you find this video helpful, and don't hesitate to reach out if you have questions about the content.